So I come from Jonesboro, Arkansas in the United States, and I will give a 20-minute session on appendage closure. Next slide, please. These are my disclosures. Next slide. So the question is, where are we with the Watchman device when it comes to safety, efficacy, leaks, implant success, device-related thrombus, etc. Next. This is the trial timeline. If you look at the Watchman trials, you can see that we started way early in 2002 with the pilot trials, and then moved on all the way up to 2020, where the Watchman Flex device was approved. And more recently in the United States, we had the Watchman Flex Pro device that got approved this year. Next. And if you look at the Watchman Flex device, it's been a huge technological advancement compared to the legacy device. There's significant difference between how the legacy device worked and the Flex device works with its closed end, with its dual row anchors, its 18-strut frame, all of it allowing us to implant the device much safely and effectively. Next. If you look at the implant videos, this is an example of an appendage. Just keep advancing to more so the videos can play. You can see that the TE image shows the appendage. Next. And you can see the angiogram and the TE imaging showing the device being deployed. And because it's so different from the legacy device with that closed distal end, you can safely advance it into the appendage and deploy it in a much coaxial fashion, giving you much more contact points, especially because of that 18-strut frame. Next slide, please. And where did we get the data for the Flex device? Came from the Pinnacle Flex trial. This was a US-only trial that looked at the safety and efficacy of the Flex device. Next. In the trial, about 400 patients were enrolled in about 29 sites, and these patients were followed for up to 24 months. Next. If you look at the success rate of the safety data, you'll see the event rates were as low as 0.5%. Let's go to the next slide. And this is looking at compared to the other Watchman trials, so Protect, Prevail, nested data. You can see this is the lowest safety data, lowest event rate that we saw compared to the other legacy device, which was at 0.5%. If you look at the DOAC discontinuation rate, that was as high as 96% in the trial. Next. And looking at efficacy, so was the implant successful? You can see 98% of the implants were successful, and there was 100% closure. Now, if you looked at complete seal, that was at 90% at 1 year. Next. And this is in comparison. This is the implant success rate comparing to the previous trials. And you can see the implant success rates have always been good, but that stayed pretty high with the Flex device as well. Next. This is looking at the 24-month secondary endpoint, which is stroke and systemic embolism, and the annualized stroke rate was 1.7%. Next. So this is a summary of the Flex trial. You can see it had good safety, it had good efficacy, good OAC discontinuation rate, and good procedural success. Next. The 24-month data also was good with the annualized stroke rate of 1.7% and no additional DRT at 1.8%. Next. Now, if you look at the anatomies that were included, with the advance with the technology with the Flex allowed us to implant it into more challenging anatomies. About 21% of patients in the Flex trial could not be implanted with a legacy device, and so that was also a huge technological advancement. Next. This is looking at the data from the US NCDR registry. It's called the SURPASS registry, so this is real-world data. And if you can just kind of click through, you'll see that the implant success rate, next please, and next, and these are all the highlights that you'll see. Next. You'll see the implant success rate, the safety data, the seal data, and one more, next please. All of them match in line with the IDE trial, so it was just as applicable in the real world as well. Next. This is flexibility data from the European registry, again showing that we had good success rates and very, very good safety events. Next. Now, where do we go from the Flex device? I mean, we already had a pretty good device, and the next device is the Flex Pro device, and let's look into what that is and how it's different. Next. So the Pro device is based on the Flex platform, so the structure of the device is still the same. Next. It has multiple additional features. One is it has a non-thrombogenic coating. So what that does is it allows for better hemocompatibility. So it allows for better healing and less device-related thrombus. Next. You'll see a bigger size comes with this, so 40 millimeter size, which allows for much bigger anatomies that can be included. Next. And also, it has these radiopaque markers that allow for you to better see the device. Next. And if you look at those radiopaque markers, can you play that? Just advance it. Okay, that's all right. So you'll see that as you deploy the device, those radiopaque markers line at the level of where the maximum dimension is, so you can actually plan for those markers to land right at the ostium. And when you do a tug test, you can actually look at the relative position of those markers, and it'll tell you whether you have had any displacement. So it really lets you look at the device very well on fluoroscopy. Next. Go ahead and play that. Next, please. Just click next. Yeah. So this is a case of a Pro device that was implanted recently. After the approval, you can see after the angiogram, we're going in with the device. You'll see those markers come out and how we align those markers to where that appendage needs to be occluded. And you can see that with single deployment, you can actually align those markers really well. Again, angiogram, all that is the same. Now, this patient is also going to go home on DAPT therapy. So these patients are followed in a registry called the HEAL LA registry, where the patients actually go home on DAPT therapy for 45 days. Next, please. The other thing that is seen is the coating, and the advantage of the coating, which is it's a PVDF HFP coating, which has been studied significantly in the drug-eluting stent world. What it is, it's an inactive coating that does not affect the mesh or the porosity of the Watchman device, but allows for quicker healing. Next. And how does it do that? This is canine model, and you can see on the left is a coated device, and on the right is uncoated device. And you can see the amount of thrombus is less in the first 2-week window. Next. This is looking at after they've been explanted at 45 days. You can see there's less thrombus on the coated device. And again, remember, these were canine models that were not on any blood thinners, any DAPT, any oral anticoagulant. So these were challenging canine models. And you can see the D-dimer percent was also extremely low in the coated device. Next. And this is looking at the fabric, the inflammatory markers on the fabric. You can see those are also extremely low on the control device or the coated device. Next. This is looking at albumin binding, which kind of suggests endothelialization, and there was more albumin binding on the coated device compared to the uncoated device. Next. This is looking at the inflammatory markers and platelet adhesion, so less platelet adhesion on the coated device, again, allowing for less DRT. Next. So combining the albumin binding, the less platelet adhesion, all of this allowing for better healing and less DRT. Next. The other thing was the larger device that comes with the Pro. So you have a 40 millimeter device, and when you look at the registry, there is at least 10% of patients that fall in this large appendage size. And now the extension is all the way up to 36 millimeters. Next, please. Next. So if you, this is a case, you can see how big that appendage is. It measured at 33, which would not be a candidate for the current 35 Flex device. So here we are implanting the Pro device, and you can see in those challenging big anatomies, it is definitely a useful addition. So allows us to get into the bigger anatomies as well. Next. So what are the other unmet needs? So if you think about imaging needs, device delivery, and let's look at post-implant regimen. Next. When you look at imaging, the things that we look for is you want to have some kind of pre-procedural imaging that is reliable and reproducible and is going to help you implant this device. Next. And CT is starting to image, come up more and more into this imaging platform. You can go to next. And there are multiple 3D segmentation tools, and TruePlan is one of those proprietary softwares that allows you to have this automated 3D segmentation. Next. And what it does is it gives all this out, spits it out for you. It automatically identifies the appendage, gives out the measurements, sizes the device for you. Next. Simplifies the procedure extremely well, allows you to figure out what transeptal route you want, helps you figure out what it's going to look on fluoroscopy. Next. Helps you pick up a fluoroscopic angle. Next. Allows you to give TE simulation views so you can be prepared ahead of time and shows you the sheet. Next. And also gives you an idea of what the device is going to look like once you have implanted it. Next. So, if you want to keep it simple, you can try to do it yourself, or it'll spit out the whole image in a PDF format for you. Next. And the newer versions, next please. The newer version of the TruePlan software even does the post-implant analysis. So if you do get a CT after, you can do post-implant analysis. You can look for thrombus. And also, if you're planning on doing ice-based implants, it'll give you ice simulation views as well. Next. What are the other imaging things? 4D ice is coming up more and more. And that's a new vision case with the 4D ice being used. Next. And that's a Philips Echo Navigator, which allows you to combine fluoroscopy and your 3D. Next. And one more, please. And you'll see that still doesn't solve all the challenges. Next. It doesn't solve all the challenges. We still have to deal with leaks. We still have to deal with canted devices, and the deployment sometimes can be harder. Next. So the first thing is, where have we come with the transeptal part? And the Baylis and the VersaCross systems have been a huge advantage when it comes to the structural world, and allow us to do a much more seamless implants with, no exchanges and stuff. Next, please. Then the question comes, okay, you got a good transeptal, but do you still, do you need steerable sheets? Because the current sheet is not steerable. And there are anatomies where it can be extremely challenging. And you saw that 40 millimeter implant that I showed you. It definitely, we could have been a little more coaxial on that. Next, please. And you can kind of click through, please. Next, just keep going. So you'll see that this is not an approved sheet, but this is the TrueSteer sheet that is being launched. Keep going. Next. And you'll see that it has a handle that helps you rotate and get deflection, but also advantages that you will be able to steer it in the middle of a deployment. So not just before implant, but in the middle of the deployment, you'll be able to steer it. Keep going. Next. It's a little bit bigger sheet. Next. It's about 17 French outer diameter. Again, it's not FDA approved currently, but is hopefully to be approved early 2024. Next. It will also be compatible with the RF Baylis transeptal system, so still be able to go single transeptal. Next. The question comes, go ahead and, play it. So what happens with the steerable sheath is you can see, that deployment with the non-steerable sheath, you can see how off-axis the device is. And if you did have the steerable sheath, and if you were able to deploy it with steerability, you'll see how the device is being engaged into that model. And then as you're deploying, you apply the steering, and you'll see how coaxial that device will land. And when the device lands coaxially, it helps with less leaks. Next. Next and next. Go ahead and click it twice, please. You'll see that when you have non-steerable sheets, sometimes what you see is you inject an angiogram and it's off axis, and you don't get a good angio shot because you have core wire bias. And with the steerable sheets, you can actually reduce those core wire biases, so you can get a good tug test. You can get a good angiogram. Next. Again, I told you that this will be compatible with the VersaCross system as well. Next. Now, how about upcoming future clinical trials? And I'll kind of summarize with this. There are trials that are looking, I talked to you about the Flex Pro device. There is a post-market registry. There are trials looking at concomitant procedures such as AF ablation and LAC. There are trials looking at optimizing therapy. The ICE LA trial had just been published, and Watchman got FDA approval for use of ice in implantation. And then there are trials looking at appendage closure as first-line therapy. Next. The trial that we're looking forward to come out next year is the option trial, which finished enrollment and is currently in follow-up. This was a trial that looked at appendage closure as first-line therapy in post-AF ablation patients. So these were patients that underwent AF ablation. They either got appendage closure at the time of the AF ablation or they got it 3 months later. Next. The Champion trial is a trial that's looking at appendage closure as first-line therapy in all comers in non-valvular atrial fibrillation. This trial has also finished enrollment and is currently in follow-up. And this is going to open this therapy up to a huge range of patient populations if this trial turns positive. And again, we'll get a lot of data from this trial. Next. We all know about the LAHRS 3 trial. This was a surgical trial that looked at appendage closure in patients who were undergoing cardiac surgery, and they got appendage closure in addition to oral anticoagulation therapy. Next, please. And there was a significant improvement in reduction in stroke in the patients that got appendage closure and oral anticoagulation. So the LAHRS 4 trial is being designed, which is going to look at percutaneous, which is the Watchman device, in addition to oral anticoagulation in this high stroke risk patient. So if there's a patient that has a CHA2DS2-VASc score of 4 or higher, we will look at this belt and suspender therapy for those patients and randomize them to OAC versus the combined strategy. Next. The HEAL-LAA is the registry that is evaluating the Watchman Flex Pro device that I just showed you, and it's going to look at the use of DAPT for 45 days, so simplifying that post-thrombotic regimen. Next. We're looking at monotherapies, so this trial is being designed as well. So this is using the Flex Pro device, so we're going to look at DAPT therapy as control, and then look at if we could use just aspirin, which is single antiplatelet therapy, or maybe a low-dose DOAC as a post-implant regimen. Next. So I'll summarize that there have been significant improvements in the technology as such, especially with the new Flex Pro device with its non-thrombogenic coating and its radiopaque markers and the larger device. We've come a long way for the device, but in addition, we have multiple trials that are ongoing looking at how we can optimize post-implant therapy, how we can evaluate this new technology and also expand the patient populations that we can treat. Thank you very much. Next.
Okay, I'm grateful that I have the opportunity to speak with you about clarity for complexity and some of the things that we've learned with high-resolution mapping, particularly with the Rhytmia system. Next. These are my disclosures. If you could advance. Next. Is it working? Great. And then next. So the evolution of high-density mapping is amazing. It's like television. And CARDO was validated with 75 points. And as we move forward next, you can see that we started looking at the EnSight system next, and looking at a couple thousand points. And I remember when we called this ultra high density mapping from UCLA, because we didn't know what to call it, because it was more than high density mapping. Next. And then the Rhytmia system really started taking next to another level, which was 8,000 or 10,000 points. But the real question is, does the density really mean anything? Is it just a pretty picture? Can we learn anything from higher resolution mapping? Next. So I was first exposed to Rhythmia at the University of Chicago, and we already had the system. Next. And we really wanted to understand how it could be used for different arrhythmias. Next. And we started with sinus node mapping. Next. And then AVNRT, and I'll show you a couple of those insights next. And then moving to the atrium, left atrial flutters, looking at the epicardium, the endocardium, and then finally ventricular tachycardia. So if you've never used Rhythmia, I always think it's very easy to start simple. Next. And next. So here would be an example, next, of understanding just principles of mapping. So here is a beautiful image of sinus node activation. And you can see that you have earliest activation at the terminal crest sitting here in the SVC where the anticipated sinus node is. Next. But what's important to emphasize for everyone in the room is mapping systems are nothing without electrograms. And now there is this tendency for all of us to map a lot and not look at electrograms as much because there's so many. And what you see here is that the onset annotation, which is manual, looks very different than if you were to have automated annotation. And this is true for every mapping system. Every mapping system will annotate however it feels like it was designed to. But sometimes when you change the annotation, you can see the sinus node here, based on automated, is up in the SVC. But if you do it onset annotation, it's at the normal location where you expect in the sinus node. So this actually can be a difference of maybe a centimeter or two, depending on how things are annotated. Next. And then we started looking at AVNRT, and we published a paper of looking at retrograde fast pathway atrial nodal connections. Next. And what we were able to describe, next, is the idea that there is a lot of heterogeneity in AVNRT. And using the Rhytmia system and putting the basket and mapping the earliest atrial activation was something that was A, fun, and B, could really help us understand the differences in retrograde fast pathway activation. Next. And what we were able to demonstrate, and this is great for the fellows in the audience, is the difference between the slow and the fast. The fast pathway is typically immediately posterior to the his, which is anteroseptal, and then the slow pathway, when you have a jump, is just anterior to the CS ostium. So that is the difference between the anatomic fast and the anatomic slow in very high resolution. Next. But what's really relevant is that there is a lot of spatial heterogeneity in AVNRT, and sometimes you have patients with retrograde fast at the anterior, sometimes you have it mid-septal, and sometimes you have it posterior, and this may have implications for the patients that have highest risk of AV block. You would imagine that posterior fast pathway might be the risk of AV block. Next. And then in this patient, we had simultaneous activation of the entire triangle of Koch within 10 milliseconds in this whole region. And this is really important because maybe in these redo AVNRTs, you want to look in much closer to examine. So this again is a nice example of clarity for complexity. I'm not saying you need to use Rhytmia for every AVNRT, but it gives you an opportunity to really study basic electrophysiology and mechanisms. Next. So is high resolution just a prettier picture? Well, I'm going to show you a pretty picture next. And this is a nice example of a Maheim pathway. Next. And what you have here is this beautiful, beautiful M potential in a Maheim pathway. And for those that haven't seen many Maheims, and you can go next and propagate this, this is exactly what Sonny Jackman has described, which is just an AV node that's on the free wall of the right atrium. Next, propagate forward. And here you can see the activation coming from the tricuspid annulus, going across the free wall, and then breaking out. And this is Maheim activation. So I do believe there is beauty to looking at this in high resolution. You can look at the electrograms where the M spike is so large, and Rhytmia has this ability to show a trend plot. The trend plot is seen here in yellow, which shows you how many electrograms are actually consistent with the M potential or the Maheim potential. So it's not just one signal that is shown. It's almost like a signal average ECG of this area. So we've loved being able to investigate these mechanisms of unusual and very normal arrhythmias. Next. And then this is a great example of what looks like a 2-to-1 atrial tachycardia. And the first thing that we did is we put with the arrhythmia catheter up into the SVC and we started mapping. Next. And what you see here is something quite beautiful. You don't always see this level of electrogram because one of the nice things about the Rhytmia system is it is printed microelectrodes. The frequency of what you're seeing is very different from a lot of the other catheters. And what you see here is very high frequency electrograms in extreme clarity, and what you see is reentry around the SVC. So this would be very easy to miss if you had low density mapping and you just went up and said, okay, this is probably some focal arrhythmia coming from the SVC, but this really allows you to explore and unveil new mechanisms. Next. So this is a beautiful SVC reentry. One of the greatest challenges of mapping is how do you eliminate noise? The biggest problem with maps is you always want to take the highest amplitude, But we also understand that some of the most relevant electrograms are of the lowest amplitude or fractionated. And this is the problem we have with all mapping systems. One thing that the system does very well, it does not allow contamination of different isochrone colors when there is one point that does not match the other surroundings. So this is like voting. If you have a different opinion and you're in blue, but you don't see it, it doesn't allow one specific point to change the whole isochrone. Next, go forward. So this blue does not contaminate the entire isochrone, whereas all the other mapping systems will do that. And this is the idea of using neighboring information. And many of the mapping systems now that we're seeing with Biosense and Abbott are starting to look at filtering mechanisms. Because when you look at this and every single point may change the isochrone, it looks very messy and looks very confusing. Next, and next. Great. And then one thing that's also very unique, which also is being done currently with the Biosense platform, is these trend plots and these skyline plots. Trend is showing you the local electrograms in one area, and then skyline is showing you all the mapping points within the entire map. So it's really beautiful to be able to aggregate all of the points with trend and skyline, which is something that we've never seen with other mapping systems. And then you can start looking for the valleys where skyline is missing some of the areas, and those regions tend to be very good sites for isthmuses that have fewer points, that have lower voltages and less representation. Next. So being able to find gaps is what we're always looking for in electrophysiology. And if you move forward and go next, you can see that anytime we're looking for a gap, next, you want to find the regions, but the gap signals tend to be continuous signals and non-split potentials. Next. So these are wide splits when you're looking at a line, and when you're looking to get closer and closer to a gap, next, then you start seeing the regions that are continuous in activation. This occurs with PVI. This occurs with a lot of what we do with reentrant arrhythmias. Next. And then the most important signals are the ones that are purely continuous, and those are the ones that we look for, and Rhytmia allows you to be able to do that. Next. Here would be one example, next, of looking at gap signals in a redo PVI. You can go ahead and animate that, and you're trying to figure out how do you get into this right-sided vein. Well, you have a very long component here, which appears that the posterior side is actually fine. With this roving electrode, what you can look at is the trend plot, and you can see that there's two populations as you're looking, which tells you there's a very wide split. As you start moving the roving catheter, then you're able to then narrow in on where the gap is. Move forward. Next. And then when you're finding the gap, it's very easy to get single burn elimination with a high degree of precision with gap mapping. Next. Great. Now, this is a very humbling image because we always use large tip ablation catheters. There's no micro ablation catheters. I want to draw your attention to ablation distal. Ablation distal has two components, that's left atrial and PV. But embedded in this system, you have microelectrodes. And look at the difference between the MiFi and the ablation distal. The MiFi looks heavily fractionated and continuous between LA and PV, but the ablation signal is very large amplitude far field. So we say, oh, this is far field, it might be intramural, it might be something else, but it's really because the recording antenna is too large. The catheter is in the same location, but the MiFi looks near field. So be careful when you say near field and far field, because nobody knows how near is, and nobody knows how far is. And it's really relevant that depending on the antenna of how you're recording may make a difference in terms of how you look at the electrograms. One looks so beautiful, so imagine how many PVC cases you do with a large tip catheter that you say it's a far field signal. And you say, oh, this might be intramural. But if you were to use microelectrodes, you might say, oh, I found a beautiful prepotential. So this is very humbling. Next. Great. And next. So this is a beautiful example of a patient that was referred to us with continuous atrial fibrillation despite a surgical maze. We went into the SVC and we put the Orion catheter there, and you see something quite beautiful. You see SVC fibrillation in the Orion catheter with variable conduction to the coronary sinus. And this here is a great example of the rare 5 or 10% of patients where the SVC is the true driver for atrial fibrillation. Really nice to be able to show the high fidelity electrograms of SVC fibrillation. Next. And if I were to ask you a question of looking at redos, which we feel like is the best system for us, is the redo left atrial, if you were to look at the CS activation next, and you were to pull up the CS activation, and I asked you, which flutter is the least likely? There is a C-shaped activation of the coronary sinus. You would probably say the least likely is mitral flutter, because usually this is linear, either proximal distal or distal to proximal. Move forward. So this is where we have a lot of, next, have a lot of ability to get humbled. Next. Next. Great. And next, you can propagate this. And we started doing high resolution activation mapping. You can actually see there's a counterclockwise circuit that is turning around the mitral annulus. This is mitral flutter. But why does it give a C-shaped activation pattern next? Because someone must have done, next, an inferior line, next, right here, which caused the activation to come around the line and back into it, which gives you a very strange coronary sinus activation. So high resolution mapping has become our gold standard, and in many laboratories, entrainment mapping is not used anymore. It's all high resolution that's more relevant. Next. Great. And then this obviously allows us to be able to look at the localized nature of reentry. With high resolution mapping, the term localized reentry started coming out. And what is localized? Is that micro reentrant? Nobody knows the size of localized, but it's not macro reentry around the whole chamber. Next, right here, next. And Vishal Luther has often called this localized reentry, but you have to be aware of pseudo reentry here as well. Next. And then it's important to understand that we still need humans with mapping. Move next. Even 1 point can make it look like something has a jump. And even here you could see it's discontinuous. It activates up, there's silence, and then it jumps forward. But if you re-annotate it, it actually looks like it's quite smooth. So even 1 point in thousands of maps can change the way things look. Next. And this here looks like a very small figure of 8 reentry on the anterior wall. What's really relevant here is everyone's wondering if you can use ILAM in the atrium just like we use in the ventricle. Next. And you can see here looks like a very small figure of 8 or a double loop pattern that goes counterclockwise around the anterior wall. Next. Well, what does this region look like in sinus rhythm? Well, there's actually low voltage on the anterior wall. Next. And then when you look here at the propagation, next, then and next, and propagate that, you can see there's an area of deceleration right where the critical site was. So we believe that in order to reduce localized reentries, using sinus rhythm isochronal late activation mapping and studying propagation may be the new PVI plus. And we're working on some new studies and proposing randomized trials of PVI plus deceleration zones. Next. So those areas here where tachycardia breaks, next, really do correlate with functional abnormal propagation with wavefront discontinuities. Next. 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 And these are the areas with isochronal crowding. Next. Great. Next. Now the challenge with mitral flutters, like all of us, we either pick an anterior line or an inferior line. Regardless of what you choose, you have to transect transmurally, and we had a nice discussion about that yesterday. Next. And if you do the inferior line, there's a coronary sinus that you have to deal with. Next, if you do an anterior line, you have to deal with the Bachman bundle. If you do a superior lateral line, you have the vein of Marshall. So these are all epicardial bridges, and we've used high density to be able to account for a lot of this. These are all epicardial structures, and I just want to show you 2 examples before we go to the ventricle when we wrap up. Next. Next. We looked at the prevalence of epicardial bridging in the atrium and how frequent we were seeing that it was requiring the outer portion with redo, and we found that 40% of the time in redos, there was often epicardial bridging. Next, how do we show that there's epicardial bridging? Well, you look for activation gaps. When you don't see anything, here is a beautiful circuit that comes around clockwise, but it doesn't look like it comes all the way around the annulus. You come down, and then it jumps out and comes around, and it looks like it's partial reentry, but it also looks focal, so this is very confusing. Next. When you start bringing in the other components of it and you use the CS, you see this can be a coronary sinus bridge for mitral flutter that is clockwise mitral flutter. Next. And next. And there's an activation gap, but when you bring the CS in, it actually makes the whole thing continuous. So this is a very classical example of inferior activation gap in the endocardium for a very typical clockwise mitral flutter. Next. And then this would be another example of using the vein of Marshall, which is very popular with ethanol, but we actually do direct epicardial mapping, and we're able to find the missing components of this flutter that jumps from the inferior mitral all the way up to the roof. And it's using the vein of Marshall that goes in the ridge to activate. How do we prove that? Well, when you put a linear catheter next in the vein of Marshall, you can see that you have the epicardial catheter that completes the coronary sinus activation, which shows you that this is using epicardial structures to sustain reentry. Next, and Dr. Cabrera has beautifully shown some different dissections of what this anatomy looks like. And this is very relevant for anyone that does any atrial fibrillation ablation or atrial flutter ablation. Next. 2D gaps are obvious. Next. And if you propagate this, you can see next, and you can see that you can propagate this, and you can see where it squeezes out. This is very obvious to everyone where there's a gap. That's not the concern. Next, this is the problem when you have activation and then you have another activation in the center, which is like an island that gets activated. And this is a three-dimensional gap. It must be using other epicardial structures to arrive to this region. Next, and it's important that this is the septal pulmonary bundle activation that we understand in atrial fibrillation. Next. And this here is the first high-resolution mapping where we went to the epicardium to explain why box isolation doesn't work. This is why Andrea Natali likes to ablate everything in the middle, because it increases the chances of eliminating the epicardial components. Next, if you look on the screen right, and you look at all the different fibers in the epicardium, next, and then you map the epicardium, next, then you can see, next, when we pace from the epicardium, next, I want you to focus your attention on the vestibular region that activates. It's all intact on the epicardium, but you don't see it on the endocardium. So this is what is happening in the 3D left atrium. Anytime you see focal activation in the endocardium, usually there is some epicardial bridge. In this case, this is why posterior wall is so challenging. Next. And next. Next. And then this is a typical Bachmann bundle activation with biatrial flutter moving over and jumping across an anterior line in the SVC. Many of you have seen this, many of you have recognized this. This did not exist before high resolution mapping in terms of the descriptions. The first descriptions were from Bordeaux. Next, and this is just using epicardial bridges. Next, next, and next. Great, next, and then this would be the beautiful anatomy highlighting next, that when you transect across, next, you have to use Bachmann's bundle next, and you have to come across this very thick region. Note that the anterior wall is transilluminated and very thin, and that's really relevant. So you can see all of this with high density mapping. Next, next, and next, next, and next. And I just want to get to the intelligent annotation. Next. Great. The most important thing to understand with ventricular tachycardia is the isthmus is the little local electrogram that is the smallest component. Most mapping systems want to annotate the largest component. That is a problem. Next, because when you look at the diastolic corridor, that is the true isthmus, and the large components are the outer loop and the QRS. Next. So when you look here, the true channel, they are the lowest voltages. Next. And then the electrograms, in sinus rhythm, they always annotate next to the largest component. And that's a problem, because that would be 1.8 next, And no mapping system wants to annotate to the smallest component. So everything you've read about voltage mapping, where there's different isthmuses, it's all potentially wrong because it's not annotating the local electrogram, which is the holy grail. But if you were to annotate the local electrogram in the smallest, you would annotate a lot of noise potentially as well. Next. So this is one final example of a ventricular tachycardia circuit that appears to you and me as focal. This looks like there's focal activation, and you should never be satisfied with just saying, oh, it looks focal. You must look at the electrograms and say, what about in diastole? And this allows a dynamic window of interest to try to highlight areas. And when you highlight areas, you see, wow, there is diastole. It just was annotating the largest components and missing diastole. So then when you re-annotate this, and you make sure with LumaPoint feature, they all get annotated, which is automated, you have a beautiful re-entrant circuit. So this happens all the time, that you're allowing the mapping system to take control, but you must control the mapping system of what is going in. It's not focal, it's re-entrant, but you have to annotate the local electrograms. Next. And these are the beautiful signals that they're always annotating the largest component and missing the smallest component. Next. Next. And next. This is a VT, single lesion, and the other thing that's a huge advancement is using local impedance for ablation. Next. Great, next. And we're finding a late potential, and we're ablating a late potential that you can see on ablation. Note that with MiFi, with the microelectrodes, it looks much more near field. This is something, again, that we have problems with large tip catheters. You ablate a late potential, and it looks like it's already gone. Next. This is also very humbling because, next, it looks like on the distal ablation, the signal is eliminated, but the system impedance drops only by 8, but the local impedance drops by 21. And this is a new feature that looking at local impedance reduction may be better because it's more sensitive than anything else. And we're always looking at system impedance rather than local tissue impedance for biophysics. Next. So next here. Great, so this is a very modest reduction in local impedance, in system impedance, but a huge reduction in system impedance, in local impedance. Next. So lessons from one lesion is the large tip ablation catheter doesn't always see what you want to see. The local impedance is much more sensitive than system impedance, and the MiFi shows the efficacy better than the large tip. So in conclusion, ladies and gentlemen, next. Next. We have high resolution mapping that really allows us to identify gaps. It allows us to explore everything from sinus node activation, AVNRT, Maheim, flutters, and VT. So hopefully I was showing you the variety of what we study with this. It's important to understand annotation is everything, regardless of what mapping system you use. And we're always very humbled by what electrograms look like and what their automated annotation is. But this allows you to do dynamic windows of interest and re-annotate with this Rhytmia system. Just remember that mapping systems are nothing but a lot of electrograms, and we must be able to control what goes into the mapping system and not be told by the mapping system what the arrhythmias are. Thank you very much.
Doctor José Llorente y el doctor Juan Carlos Díaz, por favor puedan acompañarnos, y el doctor Miguel Valderrábano, no sé.
Saludos, Milton, ¿me escuchas?
Hola, ¿qué tal? Sí, te escuchamos.
Soy el doctor Ortiz, aquí de la sala del Hospital 20 de Noviembre del ISSSTE. ¿Se escucha bien?
Sí, y fuerte.
Perfecto, muy bien. Saludos a todos los panelistas. Vamos a comentar un caso de un paciente de 76 años, masculino, el cual tiene el diagnóstico de fibrilación auricular persistente y tiene el implante de un marcapaso fuera de la unidad en el 2020. El paciente presentó un evento cerebrovascular en el 2022 y previamente a eso había presentado unos eventos cerebrovasculares transitorios. El paciente estaba anticoagulado con warfarínico y a pesar de eso hizo estos dos eventos, por lo que se le cambió a rivaroxaban. Es un paciente que tiene un CHAS-VAS de 4 puntos y un HAS-BLES de 3 puntos. Actualmente está tratado con rivaroxaban. El paciente se consideró candidato a oclusor de orejuela y a ablación de venas pulmonares. Comentamos con el paciente y, como saben, los pacientes le tienen muchísimo miedo al evento cerebrovascular y el paciente deseaba que se le pusiera solo el oclusor. Veremos si lo podemos convencer de hacerle la ablación, pero entonces por lo pronto entró a un implante de oclusor con los antecedentes que tenemos ahí. ¿La que sigue? Es un paciente que tiene una fracción de expulsión del 50% y que tiene una aurícula izquierda ligeramente dilatada, un labi de 38 y una AP de 38 milímetros, y no está dilatado del ventrículo izquierdo. La que sigue. Entonces, trae una tomografía de fuera. No tenemos las imágenes, pero se dice en la tomografía que tiene un diámetro de 27 a la entrada y una profundidad de 22, con un área de 5 y un perímetro de 80, pero aquí tenemos sobre todo el diámetro que dice 27 y la profundidad 22. La que sigue, esta en fibrilación auricular, como vemos, y ese es nuestro caso.
De dos.
Quiero comentarios de la mesa, quiero comentarios de los ponentes, de los panelistas.
¿Algún comentario del panel? Doctor, ¿quiere preguntar algo? Yo quería preguntarte, Martín, la planificación que hiciste para el cierre de orejuela, dado que es un paciente que debe tener una aurícula muy grande, ¿no? Tiene FA permanente y todo lo demás, y realmente, si bien sacamos la indicación de la ablación del aislamiento de venas pulmonares, en sí la indicación sola de colocar el cierre de orejuela con toda la planificación que hiciste, ¿hay alguna diferencia a lo que vayas a hacer? Porque tiene una aurícula grande, ¿no? Derecha.
Sí, mira, nosotros normalmente le hacemos a los pacientes un estudio porque el instituto nos solicita un estudio o tomografía o transesofágico para poderlo actualizar. Hay una plataforma nacional que los autoriza. Entonces, para que sea autorizado tiene que llevar uno u otro. En este caso, ese es el estudio que tenía y fue autorizado con esto. Nosotros de manera habitual metemos a los pacientes, la mayor parte de las veces lo hemos hecho con eco transesofágico y hemos ido evolucionando poco a poco a meter cada vez más casos con ecocardiograma intracardíaco, como es este caso. Este caso tenemos el paciente, intentamos usar prácticamente cero fluoros. Ahorita vamos a tener en unos pequeños videos que le vamos a pasar ahorita cuál es el flujo de trabajo que hicimos inicialmente para hacer la punción cero fluoros, para hacer la determinación. Normalmente usamos solo esto y procedemos a las mediciones angiográficas y por ultrasonido en el momento de la sala y decidimos el implante del dispositivo. En este caso, por enseñanza, hicimos alguna otra cosa que ahorita vamos a mostrar.
Hay una pregunta del doctor René Martín.
Hola, Martín. ¿Sí? Buenos días. ¿Me escuchas?
Saludos, René. Sí.
Soy el doctor René Jiménez. Bueno, un excelente caso, buena indicación, un chas-bas de 4 puntos. Es una adecuada indicación. Y mi pregunta sería, ¿decidieron hacerlo con eco transesofágico o eco intracardíaco? Y la segunda pregunta es si tienen al paciente con intubación, sedación general o solamente está con sedación superficial.
Sí, te digo que en este caso está sedado el paciente, en ocasiones porque es un paciente mayor y muy nervioso porque no aceptó la ablación cuando se le comentó los beneficios y todo esto, y entonces está sedado. Normalmente cuando le hacemos transesofágico, si el paciente es muy tranquilo, hacemos solo anestesia local y trabajamos muy pocas personas en la sala. Cuando, ya sabes, cuando tiene el transesofágico, pues tiene que venir el ecocardiografista y su máquina, y cuando se intuba el paciente debe haber un anestesiólogo en la sala. Entonces, estamos tratando de migrar poco a poco a tener las condiciones para hacer eco transesofágico, dejar eco transesofágico y hacer ecocardiograma intracardíaco, porque básicamente también, ya sabes, tú que hiciste la especialidad aquí, es un hospital de gran trabajo y entonces en ocasiones no nos pueden hacer los procedimientos, entonces pretendemos hacer el trabajo nosotros con eco intracardíaco y con solo los electrofisiólogos.
Gracias,
Pasamos,
Martín.
por favor, los videos.
Sí, hay una pregunta del doctor Llorente.
Sí, quería entender la indicación del cierre de orejuelas por el ACV recurrente con anticoagulación, entiendo, ¿no? Por el Haslet, porque lo cambiaron a los NOAC y se vio, ¿no hizo un estudio previo posterior para ver esto o tuvo accidente cerebrovascular independiente con el NOAC incluido?
No, con el NOAC incluido lo que se ve ahí es que en agosto de 2021 vieron un trombo. O sea, el paciente llegó por un EBC estudiado IFA con la idea de que le hiciéramos ablación y oclusión de la orejuela si era necesario, pero durante el estudio transesofágico se le vio un trombo. Estaba anticoagulado, llegó anticoagulado con cumarínicos y ahí se le cambió a rivaroxaban y se dispuso ocluir la orejuela, sobre todo porque este paciente pues ya tiene eventos cerebrovasculares y ya está anticoagulado. Si estaba anticoagulado con uno o con otro, a nosotros nos parece no tan sustancial, digamos, porque al final tener un trombo y estar anticoagulado, pues quiere decir que ese trombo se iba a soltar en algún momento, creemos nosotros. Pasamos a los videos, por favor, del inicio. Vamos a dar el flujo de trabajo inicial. Como les comento, estamos haciendo algunos procedimientos.
Ya se fue a la vena cava superior, vamos a subir nuestra punción, ahí vemos cómo la punción va subiendo hacia la vena cava superior y ahí vamos a hacer el intercambio de la guía por la aguja de punción transeptal. Ahí estamos viendo, para saber y corroborar que la aguja está arriba en la vena cava superior, vamos a hacer un flush, ahí podemos ver cómo las burbujas de agua están en la vena cava superior.
Suéltalo.
Vamos a ir bajando, vemos cómo con el ICE, vemos la punción transeptal, vemos cómo va bajando la aguja, sí, ahí va bajando, ahí va a ser tenting, ahí va a ser tenting. Suéltame.
Ahí está.
Y queremos irnos más posterior, inferior, y estamos posterior. Quítale el candado que le puse primero. Se lo puse para la otra proyección. Acomódate. Gira el horario, más horario. Ahí vemos cómo claramente estamos en la parte inferior y posterior de la aurícula izquierda. Dame tenting. Más posterior.
¿Ya sacaste la aguja?
Sí,
sácala y funciona.
Ahí pasamos. Vamos a echar burbujas. Ahí vemos cómo está la aguja, ahí vemos cómo están las burbujas en la parte posterior e inferior de la aurícula izquierda. Vamos ahora a continuar avanzando.
Ese es el flujo de trabajo.
Vamos a continuar avanzando nuestra camisa. Vemos cómo nuestra aguja se va introduciendo. Ahí pasó la camisa. Vamos a hacer el intercambio y vamos a avanzar la pura vaina. Dame la vaina para verla. Ahí vemos cómo la vaina. Dame la vaina, cabrón. Vemos cómo la vaina está.
Martín, ¿podemos ir
Ahí se llama el
avanzando
seto.
un poco, Martín?
Para el video. Para el video.
Eso.
¿Algún comentario de la
Sí.
de la mesa?
Bueno, aquí se encuentra en la mesa el doctor Miguel Valderrábano.
Sí, lamento haber llegado un poquito tarde, acabo de aterrizar. Una pregunta, el manufacturador, los de Boston, siempre insisten en que la punción transeptal se haga posterior e inferior en el septo. Y
¿Sí?
en mi opinión y en mi experiencia, desde luego inferior es importante porque una punción superior bueno, te puede desbaratar el procedimiento completamente. Pero yo creo que ellos enfatizan demasiado el que sea posterior. A mí me gusta hacer la punción, cuando uso eco intracardíaco, me gusta ver la punción de manera que cuando tengo la tiendita formada con la aguja en la fosa, se ve también la orejuela. Si en la misma imagen yo veo que la dirección que va a tomar la aguja es la misma en dirección a la orejuela, ya sé que no voy a tener problemas avanzando la camisa y accediendo a la orejuela. Muchas veces si haces una punción muy posterior, luego tienes que rotar hacia anterior, hacia adelante, y la vaina tiende la tendencia a irse a través de la válvula mitral y es más pesado. Entonces me gusta siempre hacerla quizá un poquito incluso anterior. Inferior, por supuesto, pero un poquito más anterior de lo que suele enfatizar Boston.
Perfecto, sí.
Juan Carlos, hay un comentario de Juan Carlos Díaz.
Yo estoy de acuerdo con el doctor Miguel Valderrábano. Yo creo que eso viene de la herencia de cuando teníamos el 2.5, que teníamos que tener toda la profundidad de la orejuela para insertarlo hasta el fondo, pero con estos nuevos dispositivos que son cuadraditos y requieren menos profundidad, a mí en lo personal me gustan también las punciones más anteriores, porque si la persona tiene un reach muy largo, una punción muy posterior, va a hacer palanca contra el reach y te va a empujar de manera indefectible hacia anterior, y eso va a hacer que sea más difícil alinearse coaxialmente con el cuerpo mayor de la orejuela. Entonces a mí también me gusta hacer las punciones que alcancemos a ver la orejuela y así vamos a entrar directo con la camisa. Y si le damos counterclock al sheath, pues vamos a alinearnos aún mucho más y vamos a poder entregar el dispositivo como nos mostró ahorita la doctora Davi Nair en su presentación.
Sí, a nosotros nos gustó esta punción. Es una punción que no está tan posterior y la camisa ya ve que tiene dos curvas, ya entramos a la orejuela con bastante facilidad. Entonces este es el método y la forma en que hacemos la punción por eco intracardíaco y vamos a continuar. ¿Tenemos mediciones allá? ¿Tenemos alguna medición en el video? ¿Se observa la
Sí,
imagen?
sí, sí.
Hágalo. Okay, perfecto. Antes de ingresar a la aurícula izquierda, vemos la orejuela, generalmente desde el ventrículo derecho, y una vez adentro se usan sobre todo dos visiones, una superior ligeramente afuera de la vena pulmonar, superior izquierda, y una desde la vía transmitral. En la vía transmitral no tuvimos muy buena imagen, pero aquí sí tenemos una muy buena imagen en la cual se puede observar con claridad que el paciente no tiene trombos y se hacen las mediciones. Las mediciones por ultrasonido nos han dado 25 milímetros en promedio. Y aquí la pregunta sería, ¿ustedes le harían una inyección de medio de contraste por fluoroscopía? Comentarios con de la medición y con la necesidad o no de hacerle una angiografía.
¿Algún comentario del panel?
Definitivamente yo sí sugiero hacer la medición por fluoroscopía, nos da mayor información. De hecho, cuando hacemos el procedimiento con eco transesofágico, siempre nos respaldamos con la angiografía de la orejuela, hacemos fluoroscopía y corroboramos la medición en dos proyecciones, en 20/20 de derecha y caudo y 20-20 de derecha y cráneo. Nos da mayor información, nos da mayor seguridad en la elección del tamaño del dispositivo y en mi postura yo sí sugiero realizar la fluoroscopía antes de elegir el dispositivo ideal.
Miguel, ¿tú piensas algo diferente?
Obviamente uno tiene que hacer el procedimiento de una manera que esté seguro que lo va a hacer bien. Entonces, depende también de la experiencia. Nosotros hace 3 años comenzamos a explorar la idea de que poniendo la eco intracardíaca con la aurícula izquierda podíamos obtener suficientes mediciones con suficiente garantía de poder implantarlo sin hacer angiografía. Esto comenzó con una necesidad de pacientes con insuficiencia renal en los cuales no podríamos utilizar o no estaba aconsejado utilizar contraste. Y de un caso a otro comenzamos a acumular una serie y de hecho hicimos uno con el doctor Milton Guevara aquí en México, que es parte de la serie, y publicamos una serie de 20 y tantos pacientes primero sin contraste y sin medio de contraste. Y luego ampliamos la serie a sin fluoroscopia. Porque dijimos, bueno, la razón para hacer fluoroscopia fundamentalmente es la angiografía. Para hacer la transeptal con eco intracardíaco no hace falta fluoroscopia. Y la verdad es que desde entonces llevamos ya como 47 casos de Watchman implantados solo con eco intracardíaco. Sí que es cierto que con el advenimiento de eco intracardíaco tridimensional uno está más seguro porque puede hacer mediciones en varios ángulos, pero con el eco intracardíaco tal cual se puede hacer perfectamente sin problema y uno tiende siempre a exagerar, a oversize, a ponerlo más grande para no tener sorpresas, pero poder se puede hacer. ¿Es aconsejable? Eso depende de la experiencia de cada uno y obviamente no se debe comprometer la calidad del procedimiento.
Una pregunta acá a los profesores que están. El encontrar un trombo dentro de la orejuela izquierda, en la parte distal, he leído artículos que no contraindican cerrarle la orejuela independientemente de lo que está, independientemente si usted no va a utilizar contraste dentro de la orejuela y la manipulación para lo que es esto. En su experiencia, ¿lo ha hecho o lo evitaría?
Hemos hecho 3 casos con trombo definitivo después de tratar con diferentes regímenes de anticoagulación. Lo que suele funcionar mejor es poner al paciente con warfarina con INRs de 3.5 y con eso a veces ni siquiera se va el trombo o a veces el paciente no puede tolerarlo. Y entonces hemos hecho 3 casos. Obviamente se puede hacer con el Watchman Flex, no con el antiguo, no con el 2.5, porque uno lo que no quiere es instrumentar el fondo de la orejuela donde está el trombo. Y obviamente en esos casos es desaconsejable inyectar contraste. Entonces, en esos casos se puede hacer perfectamente, hay que tener cuidado, hay que avisar al paciente. Uno de los casos lo hicimos con el Sentinel device para poder atrapar posibles émbolos.
Y lo empiezas a salvar.
Uno nunca sabe, pero en general en esas situaciones no es como para alardear, porque uno siempre quiere hacer esas situaciones, esos casos con el convencimiento de que el paciente también está aceptando los riesgos y que uno va a hacer lo mejor que pueda y en esos casos hemos salido adelante. No he hecho resonancia del cerebro, es posible que embolias subclínicas hayan pasado, sin duda. Pero mejor no saber lo que uno no puede arreglar, ¿no?
Ok, Martín, ¿podemos seguir con el caso? Estamos un poco corto de tiempo, por favor.
Sí, hicimos una angiografía y salió 25 de medición. Estamos preparando el dispositivo y les quiero mostrar esta imagen. El eco intracardíaco nosotros lo hemos utilizado mucho en arritmias, pero lo hemos utilizado, digamos, poco en estas intervenciones y una de las ideas es utilizarlo cada día más. Aquí podemos ver la imagen. ¿Tú ves estas 2 imágenes?
Sí, estamos viendo de la orejuela ahí. Bueno.
Ok, muy bien.
Ahí estás.
Entonces aquí tenemos la orejuela y se ve perfectamente. Entonces, generalmente…
Ahora estamos viendo la manipulación del dispositivo.
El dispositivo, ok, muy bien.
Martín, doctor, ¿qué tamaño decidiríamos de dispositivo? ¿Qué medida?
35. 35, René, tenemos 26 por eco, 25 por eco. Hicimos una angiografía con 20 de caudo, 20 de derecha y nos dio 27.
Y
nos dio 27.
Ok.
Y vamos por un 35.
Ok, ¿ya tienen el dispositivo ahí? ¿Ya lo
Ya.
subieron? Ok.
Lo vamos a subir.
Ok, ahí tenemos posicionada la vaina en la orejuela.
No la vemos, a ver si lo podemos ver la imagen.
Ahí está. Okay. Puede verse ahí, en el ultrasonido tienen esa imagen.
Sí, la estamos viendo.
Ok, muy bien, ha salido la bola FLET.
Tenemos la bola flex recargada en la aurícula, en la orejuela, perdón. Obviamente nosotros también procuramos utilizar lo menos fluoro posible y ya tenemos una serie de casos también con cero fluoro, con ICE. Ahorita vamos a dar algo de fluoro para corroborar y que se pueda observar cómo estamos dentro de la orejuela.
Media de contraste.
Ok, vemos cómo tenemos la bola flex.
Échame agua.
Ahí en la fluoroscopía, si la puede pasar.
Agua.
Sí, no tenemos
Aquí, Mauricio, la duda es por el eco intracardíaco no se observa totalmente la profundidad del dispositivo, a diferencia de la fluoroscopía que nos da mayor visibilidad, ¿no?
Sin duda, sin duda. Esto es un proceso que uno tiene que acostumbrarse a trabajar con imágenes parciales. Una cosa que echo de menos, a mí me gusta poner el eco intracardíaco en la vena pulmonar superior izquierda y rotar en dirección antihoraria para poder ver el lóbulo más anterior de la orejuela. En este caso, se apreciaba en la imagen de eco intracardíaco que había como una bifurcación de la orejuela, un lóbulo más posterior pegado al ventrículo izquierdo y otro que no se acababa de ver un poquito más ancho. Me gusta ver ahora que esté en dirección al anterior en la fluoroscopia. Pero sí es cierto que la imagen de cuenta cardíaca son una serie de imágenes parciales. A mí me gusta tener varias. A veces la imagen transmitral, poniendo el catéter a través de la válvula mitral y rotándolo para que el eco vaya hacia arriba, está bien. Pero mire, como está un poquito sobrecomprimido el lóbulo distal, a ver cómo queda eso.
Teníamos duda precisamente, Valderrama, íbamos a utilizar un dispositivo de menor calibre, pero por el oversizing que bien mencionabas, decidimos irnos un poco para arriba. No sé qué opinen.
Ponle color ahí, por favor.
De esa
color al dispositivo. Parece más que como la profundidad era pequeña, la porción hacia afuera de la aurícula izquierda del lóbulo está bastante bien y lo que tiene es que prácticamente está pegando en la porción distal de la orejuela, que tiene porciones más delgadas. Entonces la porción más arrugada, digamos, o más aplastada del dispositivo es ahorita vamos a medir. Mide por favor la compresión. Ahí. La profundidad del dispositivo, ¿cómo lo ven? ¿Se ve el ecocardiograma ahí? Sí.
Cuando tenemos de compresión, ¿Qué opinan? ¿Dejarían ese, agarrarían otro más pequeño, acordándonos que, como bien dijo Valderrábano, y fue lo que hicimos, lo dirigimos hacia uno de los lóbulos? Tiene un lóbulo muy corto y otro lóbulo muy largo. Entonces lo dirigimos hacia uno de los lóbulos, y esa es la imagen donde entra hacia el lóbulo más distal, ¿verdad? No sé qué opinen.
¿Cuánto de compresión tenemos?
Martín, estamos corto con el tiempo. Tenemos ya 1 minuto nada más por la transmisión. Entonces,
y lo vamos a liberar ahí.
¿cuánto tuvo de compresión? ¿Midieron?
¿En ese estamos?
Ok.
Okay.
Ok.
Otra vez. Faltaba volumen.
Nos están diciendo que tenemos 40 de compresión. Entonces vamos a hacer una recaptura y vamos a utilizar el otro dispositivo.
¿Cómo ves?
Yo no lo habría abandonado, yo no lo habría...
Tiene 40.
Me habría gustado hacer más imágenes. Tenía varias cosas a favor de ese dispositivo, que era, no tenía un hombro en el mitral y en el lado del reach parecía que el reach lo envolvía. O sea que has hecho un tug test, has tirado y estaba bien agarrado. 40% efectivamente suena como mucho, pero yo no habría tomado una decisión solo por ese número. Ahora sí que se ve que tiene como más. Mira, si pudieras avanzar el eco intracardíaco un poquito más dentro de la vena superior izquierda y rotar antihorario, ahí, rota antihorario, bueno, lo tienes recapturado, rota antihorario, y ahí estás viendo el lóbulo anterior, parcialmente, pero bueno, ahora tienes el dispositivo recapturado, no tiene sentido, pero en principio yo no habría abandonado, yo no lo habría recapturado todavía. Simplemente por tener un poquito de más imágenes y tomar una decisión con toda la información posible.
Bueno,
let me ask a question, Debbie. So they had this is a 35. They pulled it because they recaptured because the compression rate was 40%. But as you can see on the ice, it was pretty well inside the ridge, and the mitral shoulder was not that bad. So I was saying that I wouldn't have made a decision so quickly to recapture just based on the number of 40% compression, because that's a single angle, 40% measurement. You may rotate around and you may get 20, there's angles. So.
Sí, una de las cosas que nos hizo recapturarlo también fue la forma que veíamos en la fluoroscopía, que tampoco era la más adecuada. Ahí lo volvimos a recolocar en el otro lóbulo, no sé qué opinen.
Mauricio, ya nos tenemos que ir, que ustedes continúen, vamos a tener...
Bueno, tiene razón, tiene mejor aspecto ahora.
La imagen se ve mucho mejor. Bueno, vamos...
Y ahí lo vamos a liberar.
Sí. Bueno, ya acabamos, muchas gracias, portamos los tiempos, le agradezco al panel. Mauricio, vamos a desconectarnos un ratito y va a haber un espacio después, ¿sí? Gracias.
Ahí quedó liberado ya el oclusor.
Perfecto.
That device on fluoroscopy does not look 40% at all. Definitely.
Esta última fue del 20%.
Está mal medido.
Ok, esta última ya con la recolocación fue del 20%. La primera fue del 40%. Esta me están diciendo que la segunda es del 30%. Entonces yo creo que quedó en una mejor posición. La cambiamos de un lóbulo a otro. Como bien dijo Valderrábano, teníamos 2 lóbulos. Al principio nos fuimos un lóbulo muy distal y quedó una compresión muy distal del oclusor. Después esa fue mi decisión por la cual recapturarlo y tratarlo de reacomodar hacia el otro lóbulo, que fue lo que hicimos, y ya disminuyó la compresión y la forma en fluoroscopía es bastante aceptable.
¿Olor?
Y lo que comentaban, con el ICE tenemos el paciente sedado solamente, no está intubado, no hicimos eco transesofágico, ¿cómo se llama? Y con eso pues vamos avanzando. Como bien dijo Valderrábano, hay quienes están esperando el eco 3D para hacer liberación cero fluoros. Nosotros también llevamos algunos casos con ICE, con el ICE que tenemos ahorita, que es 2D, cero fluoros, y hasta ahorita no hemos tenido ninguna complicación en realizar la liberación de los oclusores, obviamente siempre con una tomografía previa para tomar las medidas y poderla corroborar con el ICE.
¿Color?
No sé si tengan alguna duda, alguna otra pregunta.
Ya se fueron. ¿Color?
Es que ahí están todavía.
¿Color? ¿Color en el
Bueno,
borde?
ya no hay tiempo, muchas gracias. Damos por finalizado el caso en vivo. Muchas gracias por su atención.